Yeah, we're good.
Good morning, everyone. Good morning. My name is Kathy Kwiatkowski. I'm the Chief Operating Officer here at the Illinois Medical District Commission. And on behalf of our CEO and Executive Director, Allison Hanson, and the entire team here, we'd like to thank you so much for being here, for being part of this important conversation. So thank you so much, Levi Moore, who is our partner in so many things, in bringing this to our attention here at the Illinois Medical District. Just, for those folks who might not be familiar with us, the IMD is both a geography and an organization. So we were established by state statute in 1941. We are the oldest medical district in the country, and we consider ourselves the most diverse as well. We are also a commission. We're governed by commissioners who are appointed by the governor, the county president, and the mayor of Chicago. And they really created this unique place and space and set of people to be able to drive conversations, community innovation, and really, being a leader and a trailblazer to the residents of our community, the city of Chicago, and those we serve, and just to be a national leader. You're sitting in this room, and we are very lucky to have conversations, about issues that are critical importance to our community. We're happy we are honored to stand on the shoulders of trailblazers. You see some of these icons in and around this room that are really have the health and longevity of our communities at the forefront. So this conversation, I thank you all, those of you who are here in person and those of you who are here online, to be taking part in this important conversation. And please, if the Illinois Medical District can be of service, we are here to do that. With that, I would like to turn it over to Dr. Karen Cheka here to kick us off for this very important conversation. Thank you, Dr. Cheka.
Thank you, Kathy. Thank you, Levi, for having me as well. My name is Karen Cheka. I'm the Executive Director of the Fortis Foundation, one of the co-sponsors here today. Sorry. I don't want to take too much time because I think the real talent is going to be the panel that's going to be answering all sorts of questions and fostering a great conversation. But just real briefly, I think everyone knows that this is a very interesting time in clinical research, probably in medicine in general, and maybe life in general. So things are changing rapidly. A lot of the funding resources that used to be there are no longer there. A lot of the initiatives that were there in years past maybe are being de-emphasized, but I think to do what we do in the best way that we can do it, we really need to emphasize things like diversity, not because we're nice people, but because it makes us stronger and because it makes us better at what we do. Having a blend of people across the country as participants in our research studies makes the research better. I want to say that again, it makes the research better. If we have a homogeneous population, the research is not that good. And I'll expand on that and say that having a diverse blend of people making the research happen, in other words, the people that are working on the research, makes the research better and stronger as well. So I think if we look at it in all layers, this is probably just something we're experiencing, everyone in every sector is experiencing. That's why I'm really glad to be here. At least to kind of just talk and facilitate these sorts of conversations about how we can make ourselves stronger and better by doing better research. And I think the panel will kind of dive into that, and I hope it's a very spirited conversation and not just more dictatorial. So please, everyone, engage and hang out and chat.
Yeah.
Formal chair?
Oh, no, over here. I just called over here. Yeah. Oh, excuse me. I can stand. Oh, no, here we go. Well, hey, everybody, thanks for coming by in person, those online. My name is Levi Moore. I'm the coordinator of the Foxville Alliance, sponsor of the Forest Foundation. And what we're going to try to do is a little bit different. As a son of realized, I couldn't go to college, right? Because the thought of me sitting in a room for 55 minutes and somebody just talking to me and I can't say anything back, I couldn't do it. And then I have to go back and do it again and again. So the plan is that we're going to introduce each one of the panelists, and they're going to talk about who they are, what their companies do in the trial space, and then it's a free for all. If you have a question, please just stand up, raise your hand, answer it. I've got a few that are planned, but yeah, it's meant to be a conversation among people that are in this sector in some way, either as a practitioner or as an advocate. So I want to start with kind of like the reason why we're here. How many of you remember your last in-person meeting when the pandemic hit? Mine was at their office at Apex Medical Research, right at like Roosevelt and the river. And they were tearing their hair out because they were doing a clinical trial for AstraZeneca. And they weren't able, they were short either African American people or Hispanic people or maybe both. And that was sort of like where we came up, I feel, with this idea for the M3R campaign, which stands for more, first word, in medical research, especially minorities. I want to start with Nezra because really, this is how to tell us about Apex Medical Research and just a sense of who you are and your work.
Thank you, Levi, and the organizers for letting us to discuss this very important topic. I am the CEO of Apex Medical Research, founding member. We started in 2005, conducting clinical trials in various therapeutic areas, from hypertension, diabetes, osteoarthritis. So basically across the board, we cover all therapeutic areas except oncology. We grew with one physician, one employee, to now there are more than 15 physicians in various therapeutic areas, adding more than 15 employees. And like you said, before COVID, we were struggling, and our biggest struggle is always with patient recruitment. More than 60% of the trials do not meet their enrollment or time targets due to enrollment, due to recruitment challenges. And fortunately, we have kind of cracked the code of most of the trials, and we are a high enrolling site for more than 86% of clinical trials across the board. So, a majority of our patients are minority, but like you said, some studies we do struggle. We are not able to enroll patients because of multiple reasons, and one of them is of course the criteria. Because it's so tough to get the inclusion criteria and the protocol. So, but we are here, we are growing, and we're proud to be part of this journey.
Yeah. I know pretty much. Well, actually, I don't. There was the old Invenio, and then there's the new Invenio. But I really don't know much about Cedar Cross research. So,
We're actually neighbors. So,
Yes.
my name's Jamie, and I'm CEO of Cedar Cross Research Center. I've been there for probably 25 for 25 years now, working with RPI, Dr. Dan Espino, pretty well-known in the research industry. And similar to Apex, we are a small independent site, which is quite rare now because most of these sites have been either bought out by a network or they're part of an SMO. So it's kind of rare when you have independent sites like ours. Very similar to Apex, we have a wide range of different trials that we conduct. And so anywhere from type 2 diabetes, hypertension, COPD, asthma, pain, migraine headache. And we feel the same where we've kind of cracked the code with recruiting minority population. And there are a lot of contributing factors to that. We know that it's absolutely important that we enroll these diverse populations so that we can see how these medications work in all types of cultures and populations, and not just an overrepresented group that we know has been historically proven. So we do really well with enrolling the African American Hispanic population. And we believe that it's because we have a very diverse group of medical professionals on our team. And so they feel very connected to us. They feel that they're looking at someone that's similar to them that understands them. So yeah, I'm really excited about this. I love to talk about this stuff. Very passionate about it, and I appreciate everyone who contributed today.
Thank you. And well, now it's kind of funny. You meet somebody, you just kind of quit. I think we met because of Nicole Val. They introduced us, and meet Christy, and now she's like my little sister. It's been really so great meeting her and doing events with her. So, and Christy, Inside Edge, you're in kind of your role is different, let's say, from Apex to Cedar Cross. So, tell us about Inside Edge Consulting.
Yes, thank you, Levi, and it's a pleasure to be here at this panel with everyone. So, Christy Edwards, I'm with Inside Edge Consulting Group. We are a healthcare consulting agency where we work with various companies, pharmaceutical companies, to help with either clinical trial recruitment, education, or we can even assist with clinical trial other additional services as well. So what my job is I go out into medically underserved communities and I educate around the importance of clinical trials, why we should participate in clinical trials, what are clinical trials, because a lot of members that we're actually going in and trying to recruit, many of them don't understand what clinical trials are. And when there's that misunderstanding or just lack of understanding, there's a fear around it. So that is my role, and I'm really happy to be here again with the panel to discuss.
And you're a little bit different because you're in multiple cities too, right?
Yeah, so the way that Inside Edge works is, so my leg is on the educational base, but our company does a lot of client services specific to the client's needs. But our role, boots on the ground, we are all over. We're in LA, we're in Texas, we're in Atlanta, we're in Florida, we're in Jersey, New York. My territory is Chicago and Detroit, so I do a lot of this work here in the city and also Detroit.
Thank you. Now, Alicia, it was funny. I got to know who the video was also through Nicole Ball. And you guys operated in one way, and now you're operating in a completely different way. So tell us about the old Invenio and now the new Invenio.
Yeah, we do have a rebranding. So thank you, Levi. Thank you for having us today. My name is Alicia Hart. I am a nurse practitioner and self-investigator with Invenio Research. And essentially, we are a community-based clinical research organization. We conduct various clinical trials in different specialty areas. So currently at our site, we have like kidney trials and cardiovascular studies, and the whole bit. Either in progress or in study startup. So much of what we center is making research or clinical research accessible and improving participation by meeting people where they are.
So we had a mobile unit, we have mobile teams, we have virtual teams, and we also now we're implementing like local research satellite sites to further our reach and expand our reach and again make clinical research accessible for residents of Chicago and the greater Chicago area. So we are rebranding. We do have we're opening a new location in Wicker Park. We have an open house next week. I have flyers if anyone is interested in attending. But yeah, so we are shifting a little bit, but we really remain committed in our mission to provide accessible clinical research for everyone, not just specific populations. And yeah, we were born out of the need to diversify clinical research because we just weren't, participating and we need science that is reliable and generalizable, like Dr. Cheka alluded to earlier. Like we need to have a representative sample. So yeah.
Yeah, aren't you like embedded in hospitals now? Or?
So we're out of the old St. Anthony's. So we have prime locations, and this will be our first location. Okay. So, that's relative. So yeah, we have one location now, and we are looking to expand in the future.
Yeah, this is something I learned with Stephen about. Also, I'm on the Walgreens Patient Advisory Board, and it's been really cool the last year, like working with people, like the majority of people like me have worked in a clinical trial. Yeah, but they are dramatic effect. And come to find out, I'm like the weird one where my doctor actually found the clinical trial for me. And I thought, oh, this is normal. And it's like, no, not at all. But so the final is Stephen Ottawale. We have known each other for like exactly a year. Yeah. It was November of last year when I got the call to be on the Patient Advisory Board. Yeah. And I got to know Stephen, and for what it's worth, we're there. He was like, and he's just slaying dragons in terms of like the work they're doing. So Stephen, tell us what and actually I was like, Walgreens is in clinical trials, like what? Like so
every time I hear Walgreens is in clinical trial, it's a reminder that there's still a lot of ground to cover and there's still a lot of work to do. So we're relentless in making sure that every single person knows that we're in clinical trials. So clinical trials, Walgreens clinical trials has been on since 2022. So we just celebrated 3 years. I would like to think of it as, or I would like people to think of it as a retail pharmacy that's using its landscape or its resources to be able to further and drive accessibility to clinical trials. And sometimes we say accessibility, but you have to realize that driving for that accessibility is not easy because, as she had alluded to, you have to figure out a space. You have to start aligning and getting relationships with. But one thing we realized with Walgreens is we have these assets called stores that it's easier for us to build that relationship and leverage the existing connections that we have in those communities. So we have 3 service lines, and our service lines are patient recruitment, decentralized clinical trials, and also real-world evidence.
Great. Okay. Let's see. I can start, but does anybody in the audience have a question for anyone else?
Yeah, I could ask general questions of everybody up here. We all speak about different approaches, and everybody's very excited and proud of what they're doing. But since COVID, at least our experience, and Measure Dean's experience, and I'm the PI for her experience, one of her sites, find it very difficult, much more difficult than it was before COVID. Profound changes. So you all have some different approaches. Walgreens is kind of fascinating. I think hospital-based, decentralized approach, great idea. Yours is much more akin to ours. Portis, Les Sandlo and I were very good friends once upon a time. And Portis is not really in research at this point, to the best of my knowledge. or certainly potentially. Which one of these you all see, where do you see it all going from this point on? I mean, do you see the decentralized approach? Do you see the Walgreens approach? Do you see the old traditional approach, which is more like we're doing, as the successor to what's happened post-COVID? Because I think COVID had a profound effect on clinical research. And I can make a lot of comments about recruitment and things like that, our own experience and the problems we have with it. But I'm curious what you all think about where it's going from this point, without necessarily saying we're best, we're the greatest, and this is the only way to go. Because I don't think there is one way to go. I think there's a lot of opportunities, but it's where you go with it.
Can I ask?
Yeah.
Okay, so where research, I'm looking at the whole healthcare area. Before 20 years ago, 25 years ago, you would see a lot of solo physician practices. They're all gone. There's no more solo practices, even group practices are all done. And we have a small cardiology practice up in Hazelcrest, but and research is also moving towards that, where solo research sites will be gone. The site networks, private equities are coming and buying sites and making networks, right? So there's a lot of site networks now, like Headlands, there's like 25, 30 sites, and they're speaking directly with pharma CEOs and getting the trials. And the small sites like ours will get the crumbs. So we have to join together, band together, work together, and make our own type of site network where we're independent, but at the same time, we have a voice. And that's when we can speak with the CROs and sponsors and say that, hey, we are now a network of 60 sites, 70 sites, whatever, and we have partners, and we will bring efficiencies, and we will bring, recruitment. We have a database. So that's where I think the research is moving towards, where the site networks will be playing a very important role. And that's the reason from one site now we have expanded to 11 sites.
Oh,
And so just in the last, after COVID, we just grew because we knew that the only way to survive was expanding, building a site network and expanding our research. And I mean, that's my.
What else?
I agree. I was just saying collaboration is going to be key. And like you said, being in a hospital or affiliated with hospitals is going to facilitate sponsors trust in us. Like we have access to populations and we have access to the ability to recruit from EMR databases. So I think that these community-based models are forward-thinking. It is redefining access. We are bringing the clinical research directly to the communities. Like you mentioned, people don't want to drive, right? And we see these very siloed research locations in academic institutions and in hospitals. And so I think, like you said, collaborating with other smaller models, collaborating with larger hospital organizations are going to push us in a position to be at the forefront of clinical research.
If I may add, I don't know if it's just the times that we are, and you can probably consider me as younger, but there's just something about being able to, right, where you're sincere and authentic. And I think that's what every one of us on this panel stands for. And it basically is being intentional about connecting with people that we're talking to. And we're not just, saying it and just, forgetting about it. And I'm not saying we're forgetting about it, but remembering that this is organic work, right? You have to have those conversations one person at a time. You have to break down those barriers one barrier at a time. And we're seeing from the conversations that we're having across our site network that it's very welcoming. And I think if we figure out a way for us to stay rooted in that, but also plan how to scale that, as you said, collaborate, then I think that the community is primed and is ready to receive that message.
Yeah, I just wanted to say something real quick to your point earlier that you made. It's really important for us to meet community where they are,
Yeah.
and that's the work that we do. And again, I'm speaking from the educational piece, but the work that we're doing now, we are truly embedded in the community where we are working in partnership with community-based organizations, providing this educational information to them directly. And through this work, we realize and recognize that a lot of people aren't really interested in research because there are other issues that they're contending with. Some people can't pay for rent. They're having to make a choice. Do I pay for my subscription? Do I pay for for my regular monthly responsibilities? So we're starting to look at social determinants of health too. That's actually starting to shift and drive the work that we're doing. So I wish I had the little glass crystal ball to be able to see where things are going. But for us, transparency is extremely key. In my education that I share with community, I share my process as a mom who had a child in a clinical trial and how that actually helped with his condition. But I think it's really important for us these days to be truly transparent, especially in the communities that have that level of mistrust and mistrust.
Right. And I think that it's very important that people like you exist to provide that education. One thing I will say during COVID, what I did notice, we shut everything down, all the trials shut down, and we all shifted right into the vaccine trials, because we knew that was the most urgent at that time. But what I did realize, and these were high enrolling, rapid enrolling trials, it brought a new awareness to clinical trials to a widespread of people. Before that, we used to always say studies, because they never understood. I mean, this is years ago, we would say study because patients wouldn't understand what a clinical trial was. And then with all of the media, with all the vaccines, during that time, people were aware that we existed, right? So, I mean, for years, you go get your medication, but you had no idea that there were people like us, and even medical professionals didn't really even know our area of work existed or thought about it too much. And so that time, I felt like it brought that new highlight on us, and finally, like, people knew we were there. But I did notice during that time with all the populations, the break in between the minority population and the distrust, especially African American, from the historical tragedies that we knew that happened in clinical research, and trying to break through those barriers and regain the trust and help them understand how important their contribution to research was. I'd love to get your card afterwards though, because I do love what you're doing, and it's absolutely essential. That's the thing people don't know. And then a lot of these underserved populations, they can't afford these medications. And we see what's going on right now with all the GLP-1s, where this is a solution for so many people, not only for weight loss, or type 2 diabetics, but they can't get it. And we're fighting with, the companies, with the insurance companies to provide the coverage for them. And we know that's the solution. So the alternative is participate in a trial where you can have access to something like that. And it's a different.
Your words are important, but you're forgetting something. The COVID story was one of fear. It was one of, if you don't get vaccinated, you don't get the monoclonal antibody, you may die. I mean, we saw hundreds of patients and the monoclonal antibody with AZ, during that trial. And the real reason was fear, fear of death. And that was the next question. Every one of you got vaccinated very quickly, as soon as you could. I'm sure doctors did. There was no doubt about it. We all did. And the reason was we were all afraid we would get COVID. And, this was at the time, Tony Fauci, regardless, we were all frightened to death of what was happening and what we were hearing from our leadership in Washington, the positive and the negative. So, I would also say something else. I'm not sure that issue of trust has really ever been eliminated. And getting back to education, I think educating West Side community, the West Side United rather, the South Side. Yeah, there's another program I know that the Michael Reese Foundation is investing in right now. People are, ignorant. They just don't know. And so there's still a great deal of mistrust. The education, but I don't know how you get that education. Do you have church meetings every week? What do you do to get people enrolled? The best The best study I can think of was the barbershop study with hypertension published in the New England some years ago, where everybody walked in and got their blood pressure checked. And they got them on blood pressure medication and they learned about it. What do you do? How do you get people educated? And that's a tough, tough problem. And I don't know that anybody here has a great answer for it. I think you got to reach out in the community, but it's a long, very hard push.
That's Christie's job.
Well,
I have my work cut out for me. But I will say, we actually meet community where they are. So if there are community organizations that have monthly, quarterly, weekly community meetings, we see if we're able to come in that way and be put on the agenda. We also have other incentives where we're able to offer our partners, but it is one of those, it is very challenging. And I also work with the Native Americans too. And that's also another population where there's a lot of mistrust, and not just around healthcare, but also around land and resources and food. So this goes, there are lots of layers, so to speak. But the only thing that we can do is just tackle one thing at a time. But we're all here and we're very passionate about improving health outcomes. So whatever that may be, and however that may look, you just try one thing. If it doesn't work, then you try another thing until you can get access.
So if I may add real quick, and this is just for me real quick, I'm excited about that challenge, but I've seen it play out and I've seen it win. With a protocol that we have with BARDA, and we have the partnership with the church on the south side, mostly faith church. I can say about 15 to 20% of people that enrolled in that study came from relationships like that, where, to Christy's point, we're actively meeting those faith-based leaders and their alliances, the First Ladies Initiative, there are alliances out there that are focused in that space, that understand the need. And if we can continue to identify those alliances, forge partnerships with them, and drive together, because we're all running down the same path. We just have to figure out how to be united in that path.
I think you're right. I think the hospital approach is another one.
Well, that's what I was
You
going to
get
say.
large population, or you can have access to large population.
That's what I was going to add. So provider education will be essential to that as well. So building provider networks, and I mean, clinical research is an underutilized modality in healthcare in general. Doctors, nurse practitioners, they don't know that this is a viable model to, prevent illness, to detect illness, and to treat illnesses. And so going out in the community, talking to, the providers as well as the community members and stakeholders in the community is a charge that we all have. At Invenio, Antoinette and I often go out into the community as nurse practitioners, and then, like you mentioned, with personal stories and being vulnerable about our personal experiences navigating clinical trial research. And so, a lot of times they're ready to grill us because the sentiment of mistrust is so flagrant. It's like, you're going to use us as guinea pigs, or what is clinical research? And so we have to do a lot of foundational teaching of clinical research when we do community engagement and when we do provider education as well, because there's a lot of myths that we need to dispel in general.
Yeah. And that gets to another point in the provider education part. Why do docs want to go into doing clinical research?
Can we get back to that, because she said her hand.
Oh, I'm sorry.
Hi, how are you? My name is Laura Strahan. I work at University of Illinois Chicago Cancer Center. I work with community-based clinical trials. So the program I work for is CED, Community Education Health Equity Department. So equity is that buzzword everybody don't want to use it right now. So I heard a lot of information here. So I've been working in the field. I have a background in nutrition, public health, all of this stuff, right? All of this stuff. So the first thing I always want to ask everybody: nobody defines community. You have to define community. So when you go to the CDOs and when you go to the not-for-profit organizations, it's the same population, the same people go all the time. And sometimes those people do not reach back to a lot of people in their community, and so you're going to get the same information over and over again. So I just want to make sure I point that out. So I know you guys are, I'm sorry.
Well, at Invenio, we really exhaust all of our approaches, recruitment approaches. So yes, we go into the community. Yes, we have gone into churches. We also used social media campaigns, right? So we're reaching different demographics to try to, you know, engage with the communities in different ways, because like you said, everybody doesn't go to the community organizations to, you know, learn or educate themselves. So we have AI powered recruitment efforts, and we, like I said, digital marketing campaigns, provider networks, EMR database searches. So we really exhaust all of our recruitment methods. But I agree with you, defining community is essential, and defining what your end goal and what your mission is. And then just sort of projecting that out into the different communities that you serve.
Yeah, so thank you so much for that. Because you are absolutely correct. So when you say that the word ignorant, we're not ignorant, we're just unaware. So we'll make sure you're not using the word. We're not ignorant. We're not ignoring the process. We do prefix and suffix, am I correct? So we are not aware, we're unaware of what's going on. So when I work with different populations, I work with EMR systems all the time. If we go for this thing with Epic is a really great thing, right? So I do it the slice and dice it. I get thousands of people. So then from there, because if your IRB is really strong, like at UIC, IRB is really restrictive in what you can contact people. So we can't use what's like right now, what's going on with them, some sort of lawsuit with the patient's portal. I can't think of the name right now. I just heard it on NPR. So you can't use and contact and send people that way. So we had to send letters out to people. So we had to mail letters. So then from there we did a whole entire, so what we got was a whole entire call campaign, right? And we started calling people according to the categories or the criteria in which they need to be on. And then from there we started engaging. People started asking questions. So what it is, so right now I'm in we recruiting for a Latino population, men and women, and the first thing they say when you call them, is ICE? What's going to happen? Who's going to be there? And then from there, because of me being a Black American, usually the Latino brothers talk to them, they say something like, "Sister, y'all gonna be there?" I said, "We're gonna be there. I'm gonna meet you down there." So we make sure we do safe sort of spaces, and we have to keep calling people. Sometimes the max we do is like the max I do like 3 times. You know, you think people on some people say, "Hey, I don't want, I'm not interested, I don't want to be bothered." So that is something we do, and we get a lot more people participate. So it's like we get a lot more men, Latino men, Black men to be a part of the space. It's challenging with our Asian populations because a lot of them just like they're not even if we have Asian, people who work with us, is still challenging. And then one thing that we also know is that with our Latino population, Asian population, they take in a minute, we are not all the same. We speak Spanish. We're quick, and they find that being people being ignorant to not understand it. So we have to be very careful. So there's a couple more things I'm gonna come out. So one thing when we put people in clinical trials, the main problem that we work with, I work with the cancer center, so we do all kinds of cancer. A lot of the women and a lot of men say, "Yeah, you got my data. Yeah, I was compensated. I got an incentive. What's next? How do I know what's going on?" Unless you have some sort of way in order to educate them, this is your data. This is what we found out. That was one of the main things that they always said. So you got my data. I'm done. I got this incentive. What did you do with it? So we can be able to do something like that. They will be fine. And then also, I'll say this last thing because I don't want to. So, say this last thing. Safety net hospitals, they exist. There are populations at safety net hospitals. I work out of Jackson Park. I work in safety net hospital. Y'all forget those people. You go to the bigger one, like Northwestern, Rush, University of Chicago. Safety net hospitals are struggling. And safety net hospitals have populations, and they have EMRs, and they have people that will be interested. So you'd be really surprised about the number of people at the safety net hospitals. And we can kind of collaborate and work with those safety net hospitals in the community. That'd be the best one. So that's like really small one. Thank you so much.
Hey, I have a question, and it's like changing landscape stuff. And there's 2. Has it been easier to recruit after COVID or before? And then how is your operation had to adjust for, well, it was in this room, Kathy, Terrence, when it was a Westside United event, and there were a couple of attorneys from Rush. And their little section on how to whitewash the DEI off of our websites. The world, I think I was like in February. And it was one of those, I don't believe I just sat through that, but yes, I needed to do it. So, anybody, those two kind of like shifts up. Easier to recruit after COVID, and has it changed your operation in terms of like, DEI initiatives, funding, and stuff like that. Yeah.
Okay, so, patient recruitment, I wouldn't say has changed much after COVID, but during COVID, it was something completely different. Like Dr. Robinson said, everybody was scared. Everybody that we enrolled hundreds of patients in like no time, right? In one of the studies, we enrolled 276 patients in like 6 weeks. That's unheard of. At regular times, I mean, yes, the way we recruit patients has changed. Before it was, when we used to do it 10 years, even 5 years ago, it was a lot of TV, radio ads. Now it's all social media.
Yeah.
So everybody's on TikTok, everybody's on Facebook, and so the campaigns have changed. So patient recruitment strategies have changed. But is it challenging? Yes, the challenges are there, and the challenges have increased because of protocol complexity than ever before.
Anybody else?
I'd say years ago, it was maybe about 15 to 18 years ago, it was way easier with put an ad in the paper, and then there really weren't as many IRB regulated rules for our advertising. So we have a cholesterol study, you paid $300, a visit, and your phone, you'd be in the red eye, your phone's going off the hook. Now I think there is a little bit of that. The social media has definitely helped, but with all of and for good reason, the regulations that require the kind of the hoops that we have to get approvals on with our advertising, it does make it a little bit more difficult to connect with people through our ad campaigns.
Yeah, I mean, like you said, it was easier when we did the study 20 years ago at Michael Reed. We had a elbow pain study, and the doctor said, I don't have a single patient with elbow pain, don't do this study. But we did it. We put the ad, and sometimes it was right, and we got hundreds of calls. We enrolled 18 patients in the study, and that was great. So yes, it was easier with newspaper ad. There weren't that many regulations. The budget was like, spend whatever you want, just submit us. The invoice will pay you. Now the budgets are very, very restrictive from pharmaceutical companies. They'll give you a small amount, and you have to work. And sometimes, or most of the time, we spend our own money on advertising. Before, it was like everything was funded, a lot of easier way to, recruit and, so things have changed. But yeah, the challenges remain, and, there are always ways to overcome.
Hi, my name is Andrea. I work with Alicia at IMD. Well, I have a question. It's my mind. I was thinking about it. I guess my one question is, we understand that you can recruit right from digital campaigns and community events. How do you retain your participants once you get them to enroll in the study? That's also a big issue that people don't often consider. So you get them to come in, maybe they sign up, maybe they just do a screening visit and they don't come back for randomization. How do you employ those tactics to keep them retained in the trial?
We talk about this all the time. Retention is one of the most important factors that we discuss with our team, but I believe it's your team. And you do have to have a naturally empathetic, caring, passionate team behind you, but working with you, that your patients can have that relationship with. They need to feel like they do matter, and they do. And so when they come into that, that environment, that setting, your team has to show them that they're not just a patient in a doctor's office that's got to wait there for. I mean, they have every single person that comes into that clinic needs to be treated and respected and cared for. So I think that's really key.
And adding to that, that's right, spot on. So, and adding to that, I would say it's the relationship with the physician. Once the physician is involved, and really, and key is education, awareness. To see your information is so valuable to us. thank you for participating, showing that real appreciation, being like that empathetic. And that goes along with when the patient knows that you really care for them. It's just not about research. It's like, you care for their well-being. And they do understand that. And you see that.
I just wanted to share, the work that we do, we move at the speed of trust when we're working with community. And I think research, oftentimes you have deadlines, you have, things that you have to get in by a certain time. And when working with the community, again, I'm speaking with my work and working with the community does not work that way. Especially when you're trying to build trust, when you're trying to make sure that the work that you're doing is transparent. So this is something that we talk about in our company all the time. We move at the speed of trust. So we will show up to community meetings and not even ask for anything. I've gone out to cultural events at the Native American Health and Family Services in Detroit. I've attended different events that they've done. I've attended their galas without even asking them anything. And then once I build that rapport, then that's when I'm able to say, you know what, hey, I really love working with your organization. I love what you all are doing. I would like to partner with you. And typically, because they've grown to know you, and you're moving at the speed of trust, and you have those numbers in your cell phone where you can connect and call them quickly, then they start to look at you and say, you know what, I want to support you. And so whatever it is that you need from me, let me help you. So I will bring in community folks. I will recruit people for you. I think, we have to look at different ways of, recruiting, especially when it comes to working with community folks.
Okay, we're nearing the, Terrence.
Yes. So you all mentioned recruitment and demographics, right? Being in minority communities. One of the things that Westside United has been focused on recently is age. How effective have you been, or what are the strategies that you have for reaching people at 18 to 35-year-old range, right? People, and you brought it, brother, you made me think about it as I was thinking about, like, I'm the young person on this panel. A lot of the work that we do is about preventing, reducing that age disparity, specifically is our focus. How do we get people at 18, 19, 20 to participate in these clinical trials, to participate? Because I know going to church, yeah, you get my mama, but you might not get me, and I'm a little bit older than that group too. So how do you go about, what strategies, what type of collaboration have you found is effective for pulling that group in and retain them and work with them as you're working through the process?
So I have a perfect example, and Walgreens was at the Black Women Expo. And at the Black Women Expo, there were a couple of things we did that I just so love. I mean, I love working in this space, but it just kind of reaffirmed the reason why I'm here. When everybody came into that Walgreens booth, because it was specifically focused to celebrating our Black women, we had things that could cater to that. So we had beauty products. We had things that we know that it could bring those people in. But when they came in, guess what we did? We started having conversations with them. And what you realize is some of the barriers that we're breaking down with older population, like some of these folks were not even born when Tuskegee happened, right? So the barriers they're facing are different. As Christy said, most of them may be around social determinants of health. Most of them they're so busy, they don't even have time to go to the studies. So the approach has to be different. And that's what we do. We identify influences that can help them. And right now we're beginning to work with community influencers in those spaces where they can connect directly with them. And we cannot go with a whole box approach where we start a conversation with Tuskegee and all of that. No, because they don't sometimes don't even have an idea of or clue of what that is. So I think it's the approach and making sure that we're working with them around the things that influence them, around the things that they spend time with, right? And that's why I was so excited with seeing a lot of young people opt in and say, you know what, I want to participate in clinical trials. I was like, okay, this is good, because the booth that we had was catered to younger people, beauty, things that they love.
I would comment though that that's very dependent on the diseases you're talking about. This is critical. You're talking hypertension, talking obesity. You can engage a younger population. Talk about lupus in Black women. You probably speak to a younger population. Talk about Alzheimer's disease. Talk about osteoarthritis. Talk about more chronic diseases, heart failure, etc. You're talking to an older population. But that's very dependent. I would respond that based on the disease category that you're looking at.
I think that's what we all have done very well, it sounds like. We all have like a people first approach, right? You need to assess and see what the needs are of the community, of the age group, of whatever demographic that you are looking to recruit. I think that we just need to humanize the recruitment process. So if we are dealing with 18-year-olds, 18 and up, maybe we're looking at social media campaigns. Like you said, we are meeting them where they are. Y'all like beauty products? Here you go, but let's talk about something else so that we can keep you healthy while you are, looking pretty, So I think the future of recruitment really lies in bridging the gap between the science that drives discovery and the humanity that drives participation. So yeah, you just have to humanize the people, humanize the demographic that you're engaging with.
I was at an event, I was a Better Business Bureau, and I asked this innocent question about this kind of thing I was saying. I sparked an argument between someone from a millennial, someone from Generation X, and someone Generation Z. Oh, so you all are different. Okay. There is a question in the chat.
Yes. All right. The question is, once a trial concludes, how are findings communicated back to the communities who participated, especially when the results may influence future care access or policy?
Wow, that's a good one.
We don't.
That's a very good question. Unfortunately, we don't. I mean, once the trial is over, we tell the patients the study is over, please follow up with your PCP, end of story. But that's something that definitely, I think we have to do a lot of work in that still.
But that's also part of Big Pharma to do with the health care.
Yes.
Because they're the ones analyzing the data, publishing the papers, putting out the news bulletins about a new drug and a new application or whatever. And that information doesn't come back to us regularly.
It takes a while.
It really takes a while, and by the time it comes back, it may be a year or two down the road, and you've forgotten.
Or you've been working on the trial, and you see an article in Medscape that you're like, well, I didn't know that while you're working on the trial.
Yeah.
I think as a people we're in the same boat as the community. We don't own that data either. Big Pharma does, right? So what we don't know is the same things that you don't know. They're not telling us, and we're not telling them. None of us know.
However, we have, with many of our participants are, they stay with us for years, 15, 20 years. And so they're often returning to participate in another trial. So we do have, we're able to provide, their recent lab work, and they can see that, oh, that last study definitely did benefit, my HbA1c. I'd like to go into another study now, and they continue to stay with us. So in that way, they kind of have, or they see, oh, my blood pressure really improved. I think I want to come back and participate in another study.
So okay. So quickly, so as I mentioned that I'm more focused on education, but some of our clients are pharmaceutical companies, and they are very open and receptive to hearing feedback about this data. And so anytime we go into communities and we educate them, there is a pre and a post program survey. If they ask, like when I worked with the Native Americans, they ask, can you come back and summarize or share the data? Even though the data that I'm looking at is kind of trivial, why would you want to know whether or not, you understand about clinical trials, whether your doctors talk to you about clinical trials? Ask me for this, and I want to be transparent with my work. So absolutely. So we go back and we share that information with our community partners because we want to make sure, again, we are at the education piece where we are building trust. So we are very transparent, and we will report that and share that data back.
Okay. Does anybody have anything coming up soon that you would like to announce? Because the way I'm going to do this is, since we recorded it, I'll get it, we'll post it on Foxglove YouTube channel, on the Foxglove website, and I've learned this little trick where I can actually edit a video, a YouTube video, so I can cut it up into like 5 minutes, 3 minutes, and sometimes even 90 seconds. Even 90 seconds. There were so many, great statements. So anybody have anything coming up right now?
Weight loss and diabetes is very big right now. Hypertension, migraine.
I would say diabetes, cardiovascular disease. They're working on lupus, Sjogren's, osteoarthritis, rheumatoid arthritis. So yes, quite a few.
We have an AMKD study that's a genetically mediated kidney disease, some psych studies, pediatric schizophrenia, adult schizophrenia, mild depressive disorder, bipolar depression, COPD, and some cardiovascular like hyperlipidemia study.
So one thing that I'm doing about is I want to invite everyone, audience, panel, to visit our sites in Chicago, right? Most of the time we imagine a Walgreens store where we go pick up prescriptions, but feel free to go to our sites and experience immerse yourself in that experience of being in a clinical trial space. We have 4 sites. We have a site in Hyde Park. We have a site in Oak Park. We have a site in River Forest, and then we have a site on the southwest side of Chicago. So we're kind of spread intentionally, and at those sites we're also recruiting for studies as well. As she had mentioned, we have a site that we're also recruiting for at the Oak Park site. It's a weight loss study, and then we also have a cardiovascular disease study that's on the south side of Chicago as well too. So yeah.
You interact with any other sites, clinical trial sites, or is everything done out of Walgreens?
Everything's done out of Walgreens.
Everything is done out of Walgreens.
Out of a specific Walgreens site, because not every Walgreens store has a clinical trial space.
Okay, folks, we're in overtime, and I know you have a lot of stuff to do. Actually, we actually are going to do a canned TV show in hour and 45 minutes. So, but I wanted to thank Fortis Foundation for being co-sponsors. IMD, love you folks, all the help you get, and I learned something like I need to call the whole because I don't know how to do anything in terms of what comes in. So I really appreciate it. The panelists, thank you. And I will send something out when the video is up there, the various edited versions. So enjoy the rest of your day and be mindful that it might snow on Sunday.
Thank you.